Have you wondered what financial advisors actually think about finances? This is your sneak peek at the conversations within Financial Design Studio. Michelle Smallenberger, the CEO here, will be your host as you go behind the designs.
All right. Hello, everyone, and welcome back to Behind the Designs. My name is Michelle Smallenberger, and I'm your host. Today's topic is one that we've been super excited to discuss on our podcast. We want to talk about how to plan for your aging parents' healthcare. This is something we talk a lot about in the office, or, we might have friends who their parents are going through things like this. And as we build plans for clients that provide for them and their families, this becomes ever more important. However, we wanted to bring in a medical professional to provide a kind of boots on the ground perspective of this issue. So just from a different perspective than financially. So this is going to be helpful. So I'd like to welcome Leah McNamara. Welcome, Leah.
Hi, thank you so much.
Yes, thanks for being here. I'm excited for what you have to share. Why don't you tell us a little bit about who you are to start us off?
Yes, hi. I'm so grateful you're hosting an episode to talk about some healthcare options, and I'm happy to be a part of it, specifically because I've witnessed the difference it makes when families get proper education and care and the peace it can bring in what is often one of the most stressful times of several of the involved parties' lives. So yes, thank you for having me. It is truly by God's grace and His sovereignty that I am a registered nurse with my bachelor's degree. I remember walking through the rigorous nursing program and thinking how much information there was to take in, and I can't do this on my own. The Lord really was my strength, and my husband also supported me every step of the way. So since then, I've been in the field for 6.5 years, beginning as a patient care technician in the intensive care unit, or the ICU. It's also called the critical care unit. And I've been a nurse there for over 4 years now in that same unit. So as part of my medical experience, I've actually also been recruited to be part of my home church's medical response team, as well as a member of the same church's faithful medical decisions team, which is essentially a team that people can consult if they have some questions about their beliefs and the medical options available to them. We can kind of help counsel and guide them on that.
Yeah, I think it's really helpful because that's how, I think we got connected was I knew this team existed at church, and I said, wait, these are, doctors, nurses that want to volunteer their time to help people, because I think, as we were even talking before this, it's not necessarily an if, things like this happen, whether it's for, our immediate like spouse or kids, but a parent, it's more of when something happens, and we don't know how or what that's going to look like, but it's just being prepared for when that does happen. And I'm sure you, over the past 4 years, as you've been a nurse, I bet you've seen a lot of just how healthcare has changed even too. Do you feel like it's been a big change?
Yeah, I have family and friends that have been in the medical field. And what I can speak to, fun fact, is actually that I did start at the peak of COVID. It was April of 2020.
Wow.
So that was my orientation.
Mm-hmm.
And there were some pretty important lessons that I specifically learned.
Mm-hmm.
And it had a lot to do with advanced directives and discharge planning the moment somebody even walks into a hospital. And so what I have witnessed is the change that can come about when there are case managers and social workers involved in patients' care. And when they have the appropriate consults, whether that's palliative or hospice care upon leaving the hospital, somebody to walk them through advanced directives, which is sometimes the spiritual care consult. And those will make all of the difference.
No, that's really helpful. And I know we're going to get into a lot of these pieces. So I think this will really help people. I think the other thing that I'm just struck with is, like you said, walking into, whether it's an emergency room or whether it's walking into the hospital or whether it's getting into an ambulance, that's not the time, ideally, to be making those decisions. You really want to have made some of these beforehand, the ones that you can. And then it's, as as you're able to and as you need to decide. So as much as we can, we want to prepare, but at the same time, sometimes we can't prepare for everything. So yeah, no, that's really helpful. I'm excited to talk about all of these things. So we're going to dive in. So I guess how you kind of talked about, a little bit of what you do, kind of how you got started, but how did you even get into this profession to begin with?
So I chose nursing as a profession out of a desire to know more about how the human body works. My belief is that God created it. I have seen the stamina that we have, and it was really always my favorite subject. So as I got older and I started talking and thinking about nursing, my sister-in-law was actually a nurse in critical care on the same unit that I am today. And she told me a little bit about it. Critical care is a specialty, and it was one in which I could utilize almost all of the skills and subjects that I learned about in nursing school. And that was intriguing. So in that unit, care for a lot of patients with multiple comorbidities, or put another way, they have several diseases or health issues that need careful and precise attention from each specialty doctor they see. That actually gives me the opportunity to interact with many different consult or specialty doctors, cardiologists. A lot of people know them as the heart doctor, or pulmonology, which is lungs. There's endocrinology and cancer specialists and neuro. And my hospital actually specializes in the neuro field. Okay. So I see a lot of stroke patients, people who need brain surgery. But when a stroke happens, it's exactly that. Someone's leg stops working and they end up then having increased symptoms potentially, and we have to get them help fast. And so making a decision about what their quality of life would look like is not easy to do when the emotions are heightened and the stress is roaring.
Yeah, I think that's kind of speaks to that piece of there are things you can decide in advance, like who's going to make decisions for me, but you don't know what decisions those are going to be until something happens. So that's where we can only do as much planning as is really possible. But I'm going to have you kind of break down the difference in some of these pieces, like the types of care, because I do think that's helpful for people to understand. So that's helpful to know, and kind of interesting how you like the piece that you do because you get to interact with different specialists. So it's kind of bringing all of those together to then decide, maybe how to move forward. So it's not just one issue, but a lot of things happening at the same time. Tell us a little bit more. I know you're really passionate about some of these end of life decisions, beginning of life decisions. Tell us a little bit more about that and just kind of your passion from that.
Yeah, passionate is the appropriate word. And it stems from seeing the difference that honest communication paired with sympathy can make in such heart-wrenching times. And as I mentioned before, in some of these situations that families find themselves, especially if it's unexpected, it's often one of the most difficult and confusing and heartbreaking times of their life. And in those moments, the attitude of whichever member of the care team to walk into that room is paramount. It can be the difference between families able to grieve in comfort and peace, knowing their loved one is in good hands because the care team has taken appropriate time to explain the plan of care, explain the actions, and make them feel a part of the decision, versus a family who will angrily accuse the care team of not telling the whole story. And they're hearing conflicting opinions between providers, or they're feeling like the care is not genuine. The result is now an angry family who doesn't trust those making decisions for their loved one. And so it's truly my passion to be somebody who can walk into the room and be a voice of honest comfort. Sometimes the truth is not easy to hear, but it's a lot easier to hear when you can say it with sympathy and they can see in your eyes that you're just telling the truth, and it's not easy for them to hear, but you're not going to lie to them, and that they don't have to be alone when they're walking through it. We're there to guide them through it.
Yeah. Do you think so I just think about in the beginning, how you're saying as a professional, you're walking into the room and you want to bring peace and comfort and probably confidence in your ability and the other medical professionals' ability that are involved. And I do think, you're saying from the beginning, I want them to trust us. And that trust is important because later, and as they have to make decisions, as you have to help walk them through what's next. So what's this course of treatment? What does this look like? What is the prognosis? Is this going to be something hard? Is this going to be easier? Whatever those things are, I think that trust becomes even so much more important because you want that whole process to go well. So if you start it well, do you feel like it usually continues well and they're not in the back of their mind kind of trying to decide, do they even trust you? So you've kind of already crossed that bridge. Now they know we're on the same team. Or do you feel like, no, it can go either way? What is, I guess, in your experience, what do you normally see?
I like what you said about initially coming into the room and establishing trust and it going well for the duration of their stay. That is true. It's important that the care, we call it the continuity of care.
Okay. Yes.
The continuity of care would be, for example, if I'm getting off shift, I've had 12 hours with this patient and I am giving a report to the next nurse. I need to relay all of the proper information to this nurse and then inform the family that I have relayed that information. And typically that might look like the number one worry or the number one priority that was mentioned to me by the patient or the family. I will relay to the incoming nurse, and then I will tell the family, hey, they know about your own home medication that's labeled in the drawer, and they're going to give that to you at 9 p.m. tonight. That really eases a lot of their fears. And as far as trust goes, there's another key that I like to use, which is just being honest when I don't know the answer to a question. Making things up is never the route to go. It's never the route to take. And so I will confidently tell somebody that I don't know, or that there is somebody who is paid more than I am to answer your question for you. There is somebody who can explain this disease process or this prognosis better than I can. That's a question for the doctor. And they trust you. They trust you when you say, I'm going to find somebody who can answer that question better for you. I don't have to have all of the answers. My job stops at nurse. I am not a social worker. I am not a case manager. I am not the physician, but I can direct you to those people. I can advocate for you.
Yeah, I think even just hearing you kind of describe from your side as a nurse and caring for the patient, just hearing, your level of care of, okay, I've been caring for someone for 12 hours and now I'm handing off that care and I want that to go well. And for everybody, for the patient, for the family, for the next nurse coming on, I'm sure. And so all of those pieces I think are just helpful for us to understand, because some of us might be able to point back to times where we were in the hospital and we saw the changing of the shifts and that may or may not have gone well. And so I think it is helpful to even think about our own experiences. And if we don't have them, then what do we want them to be? So I think even just little things like that you're sharing are really helpful. So one of the situations that we're going to talk about, over the course of this episode here is, might sound something like this. Mom or dad has fallen and they can't come home. So we can't afford, maybe a long-term care facility that has, private care, has their own private room. But we can't care for them at home ourselves either. So we're limited, whether physically or, geographically, whatever those look like. So now what? And so this is kind of the situation where we're in the hospital, but we need to get somewhere where we can continue to be cared for. So I guess as a medical professional, just starting off, have you seen this situation before?
Absolutely.
Just play out. Okay. Yep.
Yeah.
Do you feel like, I guess with this one where it's, I don't know what my options are. I can't afford this, but I know I can't do this either. Do you feel like, I guess, is there a situation where one goes smoother than the other? Is there one, like if someone has, financially, they can afford whatever they need, or they can afford to go to one of these that maybe costs a little bit more, or they can afford for someone to come in and take care of mom or dad. Do you find that any of those emotionally are, easier for people to, I guess, manage through that process? Is it harder when they really don't know their options?
It's a lot harder when you don't know your options. Even speaking to somebody who can offer you options and resources, that is what a social worker and a case manager will do. They work in tandem, and they will look over your insurance plan if you have one. They will look over what your insurance will accept, where the best place for this patient to end up might be based off of their medical condition upon discharge. And that's going to be handled by a couple of different parties. They might need a physical therapist evaluation. They might need the physician of rehab to come and do their own assessment. And that will ultimately place them into the next recommended step.
That makes sense.
And, contributing factors to the impaired ability to participate in independent activities of daily living are usually what ends up getting people to this point where they need more help. It's more than just a broken bone or a hip that needs healing. If it were just that, they could go home. But we're talking about more than that. And so that's when your resources are going to be everything, and understanding that you do have a choice in the matter and you don't have to make it blindly.
I think that's helpful. Yeah, even those two situations where it's just something you fall in, so there's a bone that's broken and it needs to heal, versus, some of these independent living activities, like the activities of daily living. Can you just list, I know there's like a handful of them or more. What are some of those common ones that someone either needs to be able to do, or now know they can't do on their own and they need help?
Yeah, so activities of daily living, or what we call independent activities of daily living, would look like feeding yourself. Maybe it's cooking and making food, or even being able to feed yourself is a big one. Clothing and dressing yourself. It's not always driving, because people can have some impaired abilities but have transportation taken care of. It's things like hygiene and safety. How are they walking? Are they able to get around themselves? If it's in a wheelchair, great, but can they get around? Is their house built for it? So some things like that.
Yeah, no, that's helpful. Yeah, because that's where I think even just your distinction between driving versus caring for yourself, those are a really big difference. So I guess in this situation, someone's fallen, we know they can't come home. What kind of happens immediately? So someone's fallen, they're kind of taken to the emergency room. Walk us through kind of the immediate steps that you see.
Yeah, so likely either a family member or what we call EMS, or emergency medical services, 911, will take them to the emergency room. They'll go through triage, likely an admission into the hospital. That's when your stay looks like more than just an examination and an x-ray to confirm a broken bone, a splint, and they send you home, but you're now actually getting admitted. And they'll do the classic lab draws and run their tests and tell you that you'll stay X number of days. You might need a surgery, or it might be a slow heal with or without assistive devices to get around, be it crutches or a walker or a wheelchair or a new cane, something like that. Physical and occupational therapy, they're inside and or outside of the hospital. We like to try and start, I'll speak for my unit in critical care. We like to consult physical and occupational therapy as soon as possible. If somebody comes in with some kind of debilitating trauma that's going to keep them on bed rest or limit their walking and they need more assistance. So we try to get that physical therapy on as soon as possible so that they can keep up their highest level of activity. It's quite surprising how quickly people can deteriorate if they are sitting in bed and not moving. Some might think that's a good way for them to rest and heal up, but the fact of the matter is it's very healthy for our body to continue to move at our highest level of functionality. So discharge planning as well, it ought to be started beginning day one at the hospital, and it ensures proper setup of the patient needs and any helpful resources.
Yeah, I think that's some of the big things is it's kind of like once you go into the hospital, you do need to know what is this going to look like coming out? And because it does take time, I think some people, as mom or dad are in the hospital, they realize that sometimes finding these answers of where they're going to go or what care is going to look like can take longer than they think. So it is, like you pointed out, kind of thinking about that starting on day one and trying to start to think of some of those answers is really helpful. Kind of right in line with that, what do you feel like people need to be prepared to decide or be thinking about after that?
You know what? I think that one of the biggest things I try to convey to patients and families is that this patient may never return to their baseline that they had upon walking into the hospital or they had before that fall. They might have a new normal. It might look totally different. I hear a lot of families talking about their grandma or their mom who was just out swing dancing last week and she was totally fine. It's just a fall. And that fall really changed a lot for this grandma. And they are not going to get back to swing dancing. And that's really difficult to adjust those expectations. But I think that's something that people need to be prepared for, is the adjustment of expectations. And what are the limits of medical care during a hospital stay? People need to be prepared to decide what the limits are for themselves, if they're the patient or if they are and we'll talk more about this, but if they're the healthcare power of attorney and they have the say, or if they're the surrogate, what is the patient's quality of life? Because only the patient can decide this, unless they're physically or mentally unable to voice it and there are no documents written up prior. So be prepared to decide what is the patient's quality of life. What are the limits of care? In the event of an emergency, respiratory failure or cardiac arrest, does the patient wish to be intubated, or also known as placed on life support with the breathing tube? In the event of cardiac arrest, does the patient desire resuscitation with chest compressions and medications? If it's cardiac arrest, they'll also be likely intubated and put on life support. And so are we allowed to do those things? Is this what the patient would want? Or are they at an age or a place in life where they say, if something really goes wrong, I've lived my life and I'm comfortable with that being the end? Being prepared to ask the doctors if those interventions are likely to change the outcome of the patient, because sometimes, despite our best efforts, they will not change the outcome for the patient and can be, in a worst case scenario, more torturous for the patient in their last moments, as opposed to comforting or relieving.
Yeah. Can you talk us through, so I know we tell clients all the time, have documents in place, know and decide who it is that you want to make these decisions for you. So mom or dad is in the hospital. They have this healthcare power of attorney in place. So they have a document that's been drafted. As a medical professional, what is it that you're looking for? Even as you start kind of working with this patient, are you asking for those documents from people to say, who have you named in this place? Or is it something, even at the hospital that they're saying then, like, this is who I want to make decisions for me, even if they don't have a document in place? Walk us through kind of what medical professionals look to know who can make these decisions if the patient can't.
Yeah, I'll walk through sort of by the book what it ought to look like. And I can't speak for everyone. I can't say this is going to be everybody's experience, because there are individual healthcare workers out there who operate a little bit differently sometimes. But standard operating procedure is that when somebody comes in, especially if we know right off the bat that they're just elderly and they are looking very frail, does this person have any kind of advance directive? Do they have any paperwork that tells us that we are not to resuscitate this patient? Because that's illegal. If we put our hands on them when they have paperwork that says, do not resuscitate me, that's some legal trouble. And they might be pretty upset if they wake up. So just looking for that paperwork right away, but asking about who the next of kin is. So we need to know who's the next of kin, or who is legally in charge of this patient, who is the healthcare power of attorney. The healthcare power of attorney might not be the next of kin. Sometimes there's a language barrier. Sometimes the next of kin maybe is not in their right mind enough to be able to make the decisions. It might be a daughter instead of a husband. And, we can talk about the roles of those powers of attorney, but especially it's important for the doctors to know who is the next of kin or who is the one making decisions for this patient if the patient is unable. I want to say, as a rule, the patient is making the decisions for themselves. And it does not matter what the doctors think is the best thing to do. It does not matter what the sister thinks is the best thing to do. What matters is what the patient wants, as long as that patient is deemed fit to make decisions. If the patient is deemed unfit or disoriented, that's when you start to get into finding who might be able to step in and make decisions for them. So we do look for that paperwork if it exists. We're always asking about it during the admission process, and we are letting the doctors know, and we're relaying that information to them about who they're to call in the event of an emergency or to update about the surgery or what have you.
Okay. No, that's really helpful. I think that's just like a good reminder to people that if you do have these things in place, they do actually get used. So it's not something that, you spend time doing and
they're very helpful.
Nobody pays attention. That's helpful. Yeah. No, that's great. All right. So, so kind of knowing what we need to be prepared to decide kind of in these steps here. I think sometimes our own human emotions can kind of get in the way. We, like you were saying, mom was just swing dancing last week, but now, she may never again. And I think sometimes it's really hard to be able to even just admit that to ourselves because we want them to be, who they were a week ago. We want them, to live the way we want them to. And so I think it can be hard for us to even admit that and see that and know that, okay, things are going to be different going forward. So I'm sure there's a lot of emotions that are a part of this whole process. So I guess in kind of as we progress through the situation, what do you feel like people need before they leave? Kind of what are the things before you leave the hospital? This is what you need to have in place.
Well, I think that people need to be heard. I think that's very important. So if there are any healthcare workers that are listening, I would highly encourage just the practice of listening. It can make all the difference. And for the patients and for the families, speak with case managers and social workers. It's in the right of the patient and or the healthcare power of attorney to ask for a consult to a social worker. You can ask for any consults. It's primarily going to be the decision of the primary care provider as to whether or not they will grant that. You can always ask for it and just say, we have more questions. Is there anybody that we can talk to about this? And they should be able to guide you to somebody. So speak with somebody, ask questions about who is the proper resource. And, is palliative care and or hospice care appropriate? These are different, and they can spike some cortisol. They can raise your blood pressure when we hear these words or these groups, palliative or hospice. No, they're not dying, and that is something that can be sat down in a calm environment with a consult from palliative or hospice, and they can explain to you everything that they are and everything that they aren't. Palliative care is, I think that they are such a hidden gem. And I wish they weren't so hidden. But this is a consult that I would highly encourage people to speak to before leaving the hospital to clarify quality of life, because palliative care is going to specialize in symptom management. So no matter what you have, you let palliative care know what your best quality of life looks like. And if you never want to be placed on a breathing machine, you can write that down and you can make sure that that never happens to you. If you want the best pain medication there is, even if it knocks you out, then they can put that on paper for you. So ask about that. Know what resources are available for continuity of care. Here we're talking about either medical care, whether it's rehab or it's physical therapy outside of the hospital, or custodial care. That's different. Does grandma just need a friend to sit with her while she's home and help her get dressed and make her some food? That's more of custodial care. It's really helpful for people to get an up-to-date medication list because it'll be necessary at their next hospital visit. And education regarding new or ongoing medical diagnoses, that should be mandatory. Not every care provider that you come across will take the time to educate and to answer questions. It is your right to have your questions answered. So get the education for that diagnosis.
I guess just a note on that question for you. Let's say there's, mom or dad is in the hospital and the child doesn't feel like they're getting answers. They don't feel like they are understanding like some of the medical conditions, things like this. Is that something that they should are there things that they can say that would help them if they just feel like they're not getting answers or they're just kind of being rushed through this process? Is there anything they can say that medical professionals, would be aware or alerted to, okay, like I need to take this, I need to be sure that I'm taking them seriously.
Yeah.
Because I'm sure it's a judgment call too. I'm sure some people, you may have explained it 10 times versus others.
Yeah. So there's a couple contributing factors because you might have explained it 10 times and they might not be in the emotional or the mental state to hear it. And that is one of the, it's a skill, on the end of the nurse or the physician, for that timing. It's judgment. Are they ready to hear this education or are they just overwhelmed and they can't handle another thing because they have not yet processed what's actually going on? Who is the appropriate person to give the education to? But as a family member or as the patient, if you're looking for more education, you're not quite understanding everything, there are educators in certain fields. Diabetes educators, for example, if that's a new diagnosis for somebody, you can get a diabetes educator to come up to your room and sit with you and go over all of that. To be honest with you, if you're not understanding from that nurse, you can say, is there somebody else who could explain this to me? I'm just not understanding. Or can you put it a different way? Is there more time that we could set aside at a different hour to talk about this? All of those things are completely acceptable.
So from your perspective, there's, you are not trying to rush patients out just to, help the next person. You're really caring for, here's who I'm caring for today. And I want to make sure that they're well cared for and fully cared for so that they're ready to move on to the next place, whatever that looks like in their process.
Absolutely. Absolutely. And that is coming from my personal point of view and my personal perspective. Everybody deserves that. Are there days in the critical care unit that feels like the place is on fire and, I've got 18,000 things going on and one of them is to discharge this patient. It can be a temptation to fly through the education or to assume that they know what they're doing when they go home, because as humans, we do that. We project what we know to be true onto other people. What I've been doing for 6 or 7 years can feel like it's just natural. Doesn't everybody know this about diabetes? And that's not true. And so stopping and asking and saying, I don't understand, nurse, can you please explain this a little bit more? That's important, but that's going to vary from nurse to nurse. Some nurses, they don't think the same way, or they might be having a bad day. And I think that's something that we have to remember as patients and families, because I've been the family of the dying one, and you just never know what kind of a day that nurse is having. You don't know the people they've encountered that day. You are not walking in their shoes and they are not walking in your shoes. And I think just having grace for each other and maybe going outside and taking a breather, truthfully, it might sound corny, but that can change a lot of things. You also have the right to request a different care provider if you need. Say, I don't like this nurse. I don't feel like she's been contributing to our family's needs. Is there somebody else that we can take? And that happens.
I just think it's really helpful for people to hear, from your perspective. So I think this is all really helpful for people to hear. Yeah. Thank you for sharing those. So I guess, okay, once they leave the hospital, this is where we kind of start thinking about this. Like, what are the options that you see for where people can go? What does that normally look like? Kind of what are the choices?
Yeah. So normal is going to look a little bit different for everybody, right? There is no standard really for where people are going. What we want is our goal is to get people back to their highest level of functionality. And so sometimes people will go, for example, to inpatient acute rehab. They'll stay inside the hospital, but it's, several days a week of several hours a day of pretty rigorous physical and occupational therapy and training and things like that to just rehabilitate them back to where they were. And after that, they might go home, or they'll continue some physical therapy, maybe that we're more familiar with once or twice a week at a different center. There's also long-term rehab care centers where people will go if they have, like I mentioned before, maybe just several comorbidities. They have a lot more trouble getting around. They've been in the hospital for weeks. They're very debilitated. They're very weak. They can't quite handle several hours a day of rehab yet. So they're going to go to a long-term rehab center where that progress will look a little bit slower, but they'll get the proper medical care that they need at the same time. They have long-term care facilities that we're familiar with as being referred to as nursing homes. So that's where people might go if they need a new place of residency and they've got some needs that have to be attended to. This patient can no longer look after it themselves. They need some reminders. We've got home health. So people can be discharged back to their home and just have a nurse come to their house and do some care. Or they might do assisted living. This patient is pretty independent. They just need a little bit of assistance here and there and some reminders about, hey, here's your medication. But that medication is not being administered to them by the CNA or by the RN. It's being administered by the patient themselves because they know how to do it.
Just making sure that they're getting everything they need for that, wherever they're at. Yeah. Okay. So I guess in these different places, like who is it that can care for their loved one? So in these different places you've mentioned, who are the people who are typically, I guess, caring for them?
So any number of licensed professionals, depending on their primary focus of the patient at the time of discharge. So we're talking, the patient who broke their hip, but they have diabetes, and so healing is going to take a lot longer, and they can go home. They just need a nurse to come by to administer antibiotics, or certain other medications that maybe a certified nurse's assistant can't administer all on their own. And so however many times a week for however many hours a day, the nurse will just come by, check in on this patient, administer medications. They'll go have follow-up visits at their primary care physician's office. The follow-ups are almost always going to be the case. And so the providers will just follow on the patient. And that can mean either just the primary care provider who's a general practitioner and or whatever consults want to see them back. We want to see you back about your heart in 6 weeks. We want to see you back about your brain in 6 weeks, things like that. And then patients and families have the freedom to ask for those consults at any time. And so ultimately the decision, like I said, will be made by the primary care provider as to whether or not that's appropriate. But you can always ask, can you refer me to somebody that I can see about my heart when I leave this place?
That's helpful. I was even just thinking about that, like kind of what drives most of these follow-up visits. And I just think about like our kids, maybe if we want them to get better at a skill, you can always have outside coaching or extra lessons, in addition to maybe the once a week practice that they have. So, I mean, I don't know if that's a great analogy, but, in caring for someone, if, you know that they're going to have this physical therapy 3 times a week, and I guess that's where it would be consulting with the care provider is that helpful or is it not if they're doing more? So I'm sure all along the way, but I just think of, that analogy just kind of came to mind as how do we help someone, if it's continuing to heal or if it's just kind of maintaining their current state. So another episode or another, physical thing doesn't happen.
Yeah, how can we optimize their care, really? And who can we get involved that might see something that we don't? Right. That's important. It's just a few different pairs of eyes.
So I guess that I think kind of leads into like how can people pay for these different options? What is typically what typically covers this care. Why don't you walk through kind of some of those that you see?
Yeah, as far as I know, and I'm not a social worker or a case manager, I did give some of my friends a call who are in those in the business of managing cases. So they are great resources. Like I said, I'll continue to defer to them with some of these questions. But as far as my understanding goes, your typical insurance, plan dependent, of course, will often get you through your your hospital stay. B, an agreed upon amount of time going through physical rehab, and or C, an agreed upon amount of time for home health. And then once rehab is over and there is no medical continuity of care, such as home health, that's when one might get into custodial care. Who's going to take care of this patient long term? Or even in the short term sometimes, and then you don't need it so much. But custodial care has to do with the needs of a loved one who isn't safe to be home alone anymore. Essentially, they need some kind of friend or sitter to find a new living situation. And there are individual financial options available for differing needs. For Medicare, they can get on that if they're 65 years or older and they're a U.S. resident. Medicaid, depending on the financial status. And after that, you're getting into some financial plans regarding the type of caregiver that you're really looking for, because it's going to be different for everybody. And I have some nurse friends who just by word of mouth heard that there's a guy who has a tracheostomy and he is wheelchair bound, but he is completely sound mind, and he's completely oriented. He just needs some help dressing himself and cleaning up some of his medical supplies, and it has to be a nurse. Are you up for the job? And you can find people like that through some different websites and some different consultants. And so a few of those resources we can talk a little bit about. I think even you had mentioned one that was of some help for somebody that you know.
Yeah. And I do want to list kind of some of these. So I'll let you list yours too. And even, I guess the one that, recently I had heard of, and this is one, hopefully we'll have a future episode on this. It's just kind of this care, because I think a lot of times we don't know how to be an advocate if we aren't if my profession is not the medical profession. And so I don't know things I should say or can say, or questions I know or can ask. And so I think it's really helpful how this episode, we were kind of thinking of this is, there was a situation where a friend of mine was going through this exact situation. And so I think what you're sharing, Leah, is really helpful, because it's letting you know the main goal of today is to let you know there are people who can help you if you find yourself as someone who you can't or don't know what to ask, or you're not getting maybe accomplishing what it is you're wanting to, and you aren't being heard. So I'll just list the one that I heard of recently. It's Trinity Advocacy Group. And, what I heard from it is this was a person who couldn't necessarily afford, the highest, living situation. So they couldn't have this, assisted living or even independent living. They couldn't afford that, but they didn't have, zero assets. So they had a home, but they knew they couldn't go back home because their level of care was going to be needed greater than that. They couldn't be home alone. And so in finding a place, that became one of the hard things, was finding somewhere where mom could go after the hospital. And so in finding that, this advocacy group basically stepped in and kind of said, wait, you can say these things. This is what you can say. I don't feel comfortable with the care plan that we have in place for mom, or, and whatever it is, for you and what you need to say. But that these were just some of the phrases that I felt like they were given to say in this situation. And that really empowered them to say, okay, I don't feel like mom is going to be rushed out of here into a situation that is not going to be setting her up for the best level of care after she leaves the hospital. And so this was, this group was basically, charged hourly just to kind of step in as, kind of that person who's just kind of, in for mom, and the child was just stepping in to say, hey, we can help you, and let's make sure we're finding that right place. And they did. And sometimes too, I think it becomes that where they go right after the hospital isn't necessarily where they're going to stay. So even just kind of having, maybe that mindset of this is going to be where you're going to be for a little bit, and then we're going to go here, and that might be more of the permanent place. But I think that can be hard too, I'm sure, like for the patient, if they're not going home. And so, because home is where we're usually the most comfortable. Although I have heard people say like home doesn't feel like home anymore. So it is interesting. How a lot of times we think we know what the patient's thinking, but even them just dealing with that. And so I'm sure that change can be hard if they aren't going directly to where they're going to be long term. But anyway, that was just, a place that I had heard that was really helpful for this person in their situation. So hopefully it gives people hope that there are people to help. But I know you even had a great list of several places, I think, that do similar things. Do you want to share some of those, Leah?
Yes. And these are some resources I got directly from my social worker and case manager friends. And so one of these sites, there's one called A Place for Mom. So that's the first one I'll talk a little bit about. It's really a resource center that is no cost to the person they're helping navigate, find some kind of assisted living or senior living residence. And so this is just a website where you can go on, kind of punch in some information, or you can give them a call, and they are going to, at no charge to you, help you find what might be the right fit for your loved one. There's another one, it's called care.com. And it does something very similar, so we're going to talk about either groups that are advisors or they're consultants, or these are online resources to go and just browse your options. So A Place for Mom, care.com. There's another one called ElderWorks. It's a senior care consultant advisory company. So and this is directly from their website, they offer older adults, seniors, caregivers, and families information, referrals, and guidance for all types of senior housing, care, benefits, services. I was also told even the local senior services agencies, they are vetted caregiver agencies because they're licensed, so you don't have to worry about getting into any sort of legal trouble, paying under the table, that sort of thing. But you can speak with somebody who is licensed, they're attached to an agency, and they're for hire. Catholic Charities are actually in Illinois. They're contracted by Illinois' Department on Aging and Senior Services. Just all a similar thing. I know that community care programs through the Department on Aging is another place where you can find a caregiver. So all really, really good resources that are utilized all the time by the case managers throughout the hospitals in the U.S.
Yeah, I think what the point that you had made even earlier when we were talking about kind of on day one or early in the process, knowing, and once kind of is mom or dad coming home, or are they going to need to move to a facility? I think this is the stuff. These are the types of sites and the types of people that through social workers and people like this, case managers, that they can be helping you to start consider what might you like the idea of, what might the patient like the idea of, what's going to work for us. So I think this is really helpful. This is kind of that piece to just start thinking through and thinking, and also, kind of contacting them. Do they even have place? Is there even space right now at that place or this place? So that's helpful. Okay. So I guess let's talk about a little bit. So we've kind of talked about through the situation from the time coming to the hospital, being in the hospital, and then leaving and where they can go. Let's talk about even in advance of that, what are some of the things that people can put in place for themselves and or their parents? Walk through a few of those.
Yeah, so this has to do with estate planning or advanced directives and, the role of the power of attorney, right? So there's this fun little site called medicaldecisions.info. It is a wonderfully clear and simple step-by-step guide to which end-of-life medical treatments to pursue now, or how to create a document to guide future medical decisions about your health. I made one myself just for the fun of it. And actually, when my husband and I were when we had our first kid, we put together our will and things like that. And I thought only old people do this, but then you realize that I don't want anything to happen to myself and my kid to be left in somebody else's hands, and somebody else has to decide what's going on with them. So at any age, very appropriate to start pulling together some of these things. We look for if somebody has a living will. We look for if somebody has anything that they've written down or alluded to that they would want to happen to them in a hospital or that they would never want. And it's intended to help bring the patient's values and quality of life to a document that will be presented for download or for print or for safekeeping with the values and wishes that they chose. And this is all possible at medicaldecisions.info. It is so easy. And with the scratch of a pen to fill in a few blanks and the signature of oneself and 2 witnesses, the document is legal. And so that is going to be a huge help. Advanced directives can be anything, like I said, from a living will to a healthcare power of attorney form, or we also have something called it's called a POLST, Physician Order of Life Sustaining Treatment. And that's when somebody can kind of get a little bit more into the nitty gritty of, no, I don't want to be put on a breathing machine. No, I don't want to be put on life support, but I would want you to continue to give me certain medications and antibiotics. And they have predetermined little boxes that you would check. Yes, I would want this. No, I wouldn't want that. That you cannot really go outside of what they have written. You can't just write in all of your own yes to this, no to that, which some people do try. But that's sort of, that POLST form is more so something that would be put together while you're in the hospital. And you would want to leave with it so that other providers have an idea of what your wishes are. So it's not something that I would need to put together right now because that's not appropriate. I'm not in a situation that would warrant it. But when that first situation does arise, that first hospitalization happens, it is good to have. And it can be changed. You can change it at any point in time. You can rescind paperwork that says do not resuscitate this person or do not resuscitate me, as long as, again, you are of sound mind or if you are the healthcare power of attorney.
I think it's really helpful too. And a lot of times, like you even mentioned, like we think that these are documents or this is planning that older people should do or only older people do. I think it can be hard because these are hard things to think about. And I think when we're younger, we don't want to think about, we want to think about living life and living it to the fullest. And so we don't think, oh, well, we're near the end of our life. And I think, again, a lot of those emotions can get us caught up in that. But it is really important, even, we aren't touching on it today, but even like college students who are going away and may not live near their parents, it's important to have a document so that if something happens, you, the parent, can make decisions, and that they have given you the ability, because they're now adults, so they actually give you the ability to make those decisions for you. So I think that's really important. The other thing I like to tell people is, with any type of planning or estate planning, especially if you don't like the plan, if you don't like what the state might have, if you don't have someone in, who you've actually named as a power of attorney or to act on your behalf, and you don't like the thought of that just being anyone that's chosen or anyone that shows up, when you're at the hospital, then it's important that you do write it down. Most people don't like to leave things to chance. So if you care who's making decisions, then take the time to write these things down.
Absolutely.
So speaking of that, I guess let's just talk about the role of the power of attorney in health decisions. So what, we've named this person. What is their role now? What do they have to do?
Yes, it is important that people understand this, especially if you are somebody's power of attorney. They don't always even know what their role is. But a healthcare power of attorney is first and foremost, they're designated by the patient. Legally, if the patient has not designated anybody, it would be the next of kin. It might be the husband, or if there's no other family, it might be the kids or a brother or something. But they are hopefully designated by the patient. It is the job of the healthcare power of attorney to oversee, and I wish everybody could see my big, bold, underlined letters, the wishes of the patient. It is the job of the healthcare provider to power of attorney to oversee the wishes of the patient are carried out if or when the patient cannot communicate themselves. And so the POA will sign consent in place of the patient for anything requiring such documents. And they are legally, they are the only one who can make a decision regarding the patient's care if that patient is unable to do so, if they're on a breathing machine, or if they are disoriented for any reason, or in an induced coma, or suffering from trauma. Any of those things can lead to this happening. And it's not to say that families cannot come together, have a family meeting, and then there's just, they all agree upon it and there's a one designated POA who signs the paperwork. That's fine. It is only that POA who can sign the paperwork. It's not the sister with a very strong opinion. The stress is that the POA carries out the predetermined wishes of the patient and doesn't change their wishes if it can be helped, unless obviously warranted, though they do have the legal power to change whatever the patient may have previously written if maybe they're deemed unfit to decide, or if they feel like, the situation changed. And even though my loved one isn't able to see it right now the way it is, I think that they would say they want it to go this way instead. And that's a really important job. What breaks my heart is on the flip side when somebody has the power of attorney and they're making decisions for this patient from a purely selfish standpoint. They say they don't want this patient to die yet. They're not ready. They're not ready to let them go. Do everything in your power. And like I said, sometimes our best efforts are to no avail and can actually induce a lot more pain and suffering than if we were to just let nature run its course and help that person die with dignity. And so I urge people, if you are a power of attorney, do what the patient wishes, and not just what your emotions heightened in that moment might be telling you.
I think that's really helpful. And I think, would you say it's even helpful if you are someone who's named as a power of attorney for someone else, or you have a power of attorney name? Do you think it's helpful that those people, like, you would be communicating with them regularly enough to know if there's healthcare things, if there's physical things that they've noticed, or things like that? It's probably a good idea just to be sure that you're communicating with that person so that you feel like, I'm not saying like every day, but especially if they are older and you are noticing things, that you're actually aware of things that are going on in their life so that you can make the best decision for them.
Yeah, that's wildly helpful. I have run into situations as the nurse where the designated power of attorney 8 years ago is now an estranged son that wanted nothing to do with his mom and knows nothing about her care or her medication list. And, we now have to get, which this is possible. It's a good thing maybe that we touched on this. It is possible to get, you can have a spiritual care consultant come up and just give a surrogacy form. A surrogacy form is a newly named surrogate, somebody who's stepping in to make decisions for the patient. So they say, you know what? Things have changed since we wrote that healthcare power of attorney and since mom and Jason signed it, and now it's going to be the sister because she's actually been taking care of mom for the last 5 years. She's known what mom's wishes have been. And so we're just going to change things up a little bit. That is possible. But I think you made a good point, Michelle, where it should be somebody who's in pretty regular communication. Maybe the daughter who lives in California isn't the best POA for the mom that lives in Maryland.
Yeah, no, I think that's really important. And it's also helpful to know that if a change is needed, that there are things in place to that surrogacy form. I think that's helpful. So, yeah. Also is probably helpful if you can name like a couple of backups. So you have your primary power of attorney, but usually on the form it will say if this person isn't able to act when they need to, then I want this person. And if not them, then this. So even if you can add a couple of options after that, then it's not just one and now we're, out of people who are able to act.
Yep. Very possible.
All right. So I guess the last thing I want to touch on is kind of like, how do we start these conversations? I think these are always hard conversations to have, especially if you're the child who's wanting to have this conversation with your parent. But I think even parents with kids, how do I bring it up? So how do you suggest kind of how to start these conversations with each other?
It can be so touchy. Some of our stubborn parents out there, right? Or maybe you are the stubborn parent listening to this. Something I thought about was just sharing, hey, mom, I heard of this website. It's called medicaldecisions.info. And I was able to put together my own advance directive for future planning, no matter my age or state of health. It was really easy. It was something that brought me a lot of peace to do. And I could even let my kids know that I had done it. So they're not left to make decisions or wonder, have you put together any document like that yet? And that can kind of get the ball rolling into, oh yeah, I did that years ago. It's somewhere in my closet. That's great. Maybe we should look over those, and I'm not trying to scare you, but I just want to be prepared and I want to make sure that all your wishes are going to be honored. Or maybe, hey dad, I was listening to this podcast about planning for the best quality of life and all that through medical decision making. Have you given any thought to what your wishes would be if or when you're fishing and you get into a boating accident? I know you like to do that a lot. Sometimes I think about these things and, do you have any advanced directives in place? Because I know a good place to start. And then even also just bringing up, if they've thought about who they would want to make decisions, medical decisions, if they weren't able, do you think that it would be the oldest? Do you think that it would be the one who's closest to you right now? Is it going to be a sister or a brother? Or like I said, sometimes it's just a language barrier with different cultures, and maybe the daughter speaks better English and can understand the doctors and everything going on better than the husband or something. And then, hey mom, can we discuss what you deem quality of life? Like, what limits would you place on medical care? Do you know what limits? Do you know what rights you have to really alleviate future stress? And this is not something uncommon. And we do this when we plan funeral arrangements. Some people buy the lot next to their deceased loved one, and they start planning all of their funeral arrangements so that their kids don't have to do it. And they're setting money aside so that their kids don't have to come up with it and wreck their life going into debt, which, you guys see this. You deal with this all the time. This is you.
Yeah, no, I think these are all helpful ways to start the conversation, just to bring it up, because I think naturally it is when something happens to someone else that we think about it, and that's what makes us start to act, or something happens that, doesn't have long-term, really severe effects. And so, we might think, oh, that was a close call, this is something that I should actually start taking more seriously. So I think those are the natural times where we're kind of thrown into these situations. But I'm hopeful that today, as we've kind of talked through things, that just us talking about it, I think what's interesting is we're talking about this, saying, okay, when someone has fallen and they go to the hospital and now they can't come home, what are their options? And I think what happens is, as we're having this conversation, it seems almost like we've been able to have it very calmly, slowly, thoughtfully. But I think when people are put into the situations, it doesn't probably feel like that at all. It probably feels like things are moving quickly. They're moving fast. I don't know what I don't know. I don't know who can help me. Some of us have friends who are in the medical profession. Some of us don't. And so we're all in different positions of being able to actually go through these situations differently than others. So I'm hoping that this gives people an opportunity to think about it.
Absolutely.
Before they're actually put into these situations, and to know what they can do and how to think through it. Any thoughts that you kind of have, I guess, just closing thoughts or things you want to be sure that people remember, or that, you think are really important for people to consider?
I do. I would say that I want to encourage any patient who might have some kind of chronic illness, might find themselves being hospitalized time and again, to just exercise their rights. And I say that because our hope and our expectation is that when we walk through those hospital doors, people are caring for us. People are trying to help us. And like I said before, the fact of the matter is, you don't know what kind of a day that emergency room doctor is having, and you don't know what kind of a day that nurse is having. And you might truthfully be at the bottom of their priority list for that day. You don't know what kind of tragedy might have struck them. And we just, unfortunately, we cannot rely on other people to make the best decisions for ourselves. Sometimes we can, and those are the members of the care team that we hear about. That nurse who changed my life. I don't know what we would have done without her. That is my goal when I go to work, is to be that nurse, because I've heard what difference it can make. And so my encouragement to people is to be an advocate Be an advocate for yourself. Be an advocate for your family member. And as much as you are able to remember, take a deep breath and be kind to them, because they have seen this before and sometimes it can become routine. They might not care as much as you want them to, but you gently reminding them that you need them to care and that you have needs that you're requiring be met is going to motivate them to help you more than just yelling at them or putting them down or demanding somebody else. I think that mature communication can truthfully go a really long way. And there are a lot of bad experiences people have in the medical field, and it makes them want to write it all off. And it makes them angry as soon as they walk into the hospital, or they're suffering from some kind of trauma that they experienced with a different family member. That is so common. But just advocate for yourself or your family member and use your rights. You can refuse things. You can ask for things, and just be kind. It really makes all the difference. And as a healthcare professional, we want to help you more when you are kind and when you are respectful. If we ask you to leave at 8 p.m., maybe consider leaving at 8 p.m. and not demanding to stay overnight. But if you would really prefer to stay overnight, gently ask to speak with a manager. That makes all the difference in the world.
I think this is just great reminders for like our human emotional tendencies when we react in the moment and not, pause and think about, wait, how can I respond? What's my other options? Instead of being upset, can I do the opposite and say, I'm really trying to remain calm. I would really appreciate this. It'd be really helpful if you could. Thank you so much for what you've done. Could you also do this? I think there's just so many things. If we stop and if there's something we're getting ready to say, if we just say, can I turn this around and say it the opposite way? So yeah, I think those are such great reminders. Thank you so much, Leah. I feel like this has been really helpful just to know a lot of the things that are possible for us to know and ask and talk about.
I'm happy to do it. When I tell you that the social worker I spoke with on the phone, just kind of trying to prep and get some good resources for this, she was so excited I was going to be on a podcast. She said, oh, this is great. More people need to be educated in the community about this and just what their options are. And that's great because she knows, she's educating a lot of people on things that they've never heard before. And I can't imagine her frustration. Like, why has no one told you this? All of these providers should know a little something about this. But yeah, it's so good.
We always love having these conversations while we're financial advisors and we help people with their financial plan. All of life happens and our finances are affected by it. And so we always want people to know and be prepared with how to react or interact with all of these different things that can happen in life because your finances will be affected. You may be choosing where mom or dad are going to go, but you have to think about, can I afford that? How can I afford that? Where's the money going to come from? Well, who pays first? Insurance? And then do I start taking out of mom and dad's account? Those things are impacted, but there is an order of when you think about them. And so we've got to make sure that people are cared for, and then money is used when it needs to be used. So it's the right order of the pieces to each of the puzzles. So
yeah, exactly.
Great. Well, thank you. Well, thanks for joining us, Leah, and thank you for taking time to listen to this episode. If you enjoyed it, please subscribe to our podcast so you stay updated with our current conversations. You can find additional resources for this episode in our show notes at our website, financialdesignstudio.com. We'll talk to you soon.
Thanks for listening. To find any links or resources related to this episode, check out our show notes. Your host was Michelle Smollenberger, a certified financial planner and CEO. The guests featured are from Financial Design Studio, a team of experienced, fiduciary, fee-only advisors based in Chicago. Anna Lewis is the executive producer of the Behind the Designs podcast. And as always, for more information about Financial Design Studio and who we are, check out our website, financialdesignstudio.com. And final note, no content discussed on this podcast should be taken as financial advice. Financial Design Studio accepts no responsibility for your individual choices. We'll see you in the next episode.